Let me just check if I am visible to myself. I think should be okay. Let me check. Just give me a sec, please. Or if someone is seeing, please let me know if I am visible. Let me just check. Hi. Yeah. So good evening, everyone. This is the last of the quiz which we are going to do. So this was a grand test and there were 25 questions. 26 question was a farce. You'll understand why. There are 25 questions and I told that if you have done the previous year questions at least, and so many quizzes I've given, around 300 questions I've given. If you have done only these, you should be able to solve more than 20 questions. So 20 and above should be the benchmark for the NEET exam on 11th. So I'm going to start this quiz, and along with this I will tell you some important high yielding revision points as well. Okay. Alright, good. Okay, thank you very much. Sorry if I sneeze in between or something. Sorry about that. So let us start this quiz. 3, 2, 1, go. The first question is a very important question of a diabetic retinopathy. You expect one question of a diabetic retinopathy on 11th August as well. So diabetic patient who has been diagnosed with mild NPDR, already given to you diagnosis, and some hemorrhages and exudate in the retina are there. Hemorrhages can be two types: soft flame hemorrhages and nerve fiber layer, and dot and blot hemorrhages in outer plexiform layer of the retina. Exudates can be hard exudates in the outer plexiform layer due to lipoproteins are coming out, and soft exudates are cotton wool spots, that is an infarction of the nerve fiber layer. In diabetic retinopathy, the signs in outer plexiform are seen more than nerve fiber layer. This is the extra point. Quick revision. In any NPDR, the ocular treatment is wait and watch. You observe. In PDR, the treatment main is if there is new vessels, then pan retinal photocoagulation. If there is a vitreous hemorrhage, then wait for 6 months, then vitrectomy. And if there is a tractional retinal detachment, all these comes in proliferative stage of diabetic retinopathy. In tractional retinal detachment, vitreoretinal surgery is done. But in mild NPDR, the answer is you just control every diabetic retinopathy. You have to control diabetes, of course. But in NPDR at your level, only systemic diabetic control is needed. No ocular treatment for NPDR. What do you see in very mild NPDR? Quickly, microaneurysms, mild to moderate, exudates and hemorrhage, like you see in this. Severe, very severe, there is a classification 4-to-1 rule. Quickly, if I just revise, 4 quadrant hemorrhages, 1 condition, 2 quadrant venous bleeding, second condition, 1 quadrant irma, third condition. Out of these 3 conditions, if one is satisfied, it is severe NPDR. 2 are more than satisfied, that is very severe NPDR. So here the answer is only systemic blood glucose control. That is your first question. Please expect a question of diabetic retinopathy in the upcoming exam. It's a very, very important topic. Images, they can ask you for identifying very mild, the hemorrhages, flame and dot and blot, or exudates, soft and hard. Please remember, cotton wool spots are large, fluffy, yellow things. So many times I explained, and hard exudates are small, shiny yellow things. Okay. But if a diabetic retinopathy patient, any stage, has cystoid macular edema, then the answer is anti-VEGF injections. If CME word comes, CME can be due to many causes. Quickly, CME can be due to VEGF, like in venous occlusions, branch retinal vein occlusion, central retinal vein occlusion, in diabetic retinopathy, due to inflammation, like in post-cataract surgery, Irwin gas syndrome, due to inflammation like uveitis, posterior uveitis, due to drugs, very important drugs. Can someone tell me which drugs can cause cystoid macular edema? Yeah, very good. Cystoid macular edema drugs, adrenaline. That's why adrenaline is contraindicated in aphakias. Prostaglandins, high doses of niacin, and myotics, pilocarpine. And there was a question or cystoid macular edema as well. Cystoid macular edema means the thickness of the central retina is increasing. On OCT, on angiography, there is a flower petal appearance. I know many people have done that wrong as well. No, Rishi, that is wrong in your notes if you have written that. So that is the first question, diabetic retinopathy. Let's come to the second question. Good, good. Rishi, steroids are the treatment. What is the treatment of CME due to VEGF? In diabetic retinopathy, venous occlusion, anti-VEGF injections, intravitreal. Treatment of CME due to inflammation like in uveitis or post-cataract surgery, Irwin gas syndrome. Then answer is steroids or NSAIDs. And whenever drugs are implicated, stop the drugs. Okay, just identify this is a left orbit shown. M, medial wall, maxillary, lacrimal, ethmoid, and one more body of sphenoid. In the lateral wall, there is zygomatic and greater wing of sphenoid. In the roof, there is frontal bone and the lesser wing of sphenoid. In the floor, there is three bones: plasma, palatine, zygomatic, and maxillary. So A is lacrimal, B is the optic canal, D is the frontal bone, C is the zygomatic. This is a superior orbital fissure. The question is not this. This is just a quick revision of the bones. One orbit has 7 bones. The 47-year-old patient has been complaining of watering discharge from eye for a very long time, and it is told that it's an NLD obstruction. And a very long time. NLD obstruction, very long time, means chronic NLD obstruction, chronic dacrocystitis it can cause. That's why watering epiphora. Epiphora word is always when there is a increased watering due to obstruction. And there is a discharge. If you press onto the lacrimal sac area, discharge comes. That is a regurgitation over pressing of the lacrimal sac area. That is done in chronic dacrocystitis, chronic NLD obstruction. And what surgery is planned? The surgery planned is DCR, dacryocysto-rhinostomy. Which of the following bones is manipulated? DCR, you make an opening in the middle meatus of the bone and the lacrimal fossa. Lacrimal fossa made by 2 bones, M and L. Here answer is L, that is A option is correct, that is lacrimal bone, DCR operation. 3 contraindication of DCR: it cannot be done in acute dacryocystitis, cannot be done in age less than 4 years because arbor bones are not developed till then. It should also not be done in patients who have fibrosed lacrimal sac. Fibrosed sac, like in lacrimal sac tumors, granulomatous conditions like TB, sarcoid, leprosy. In that, dacrocystectomy is done. Take out the lacrimal sac. So that is the second question. That is DCR. DCR is also important. And this is the third which I was telling you. This is a angiography of the right retina showing a central hyperfluorescence in a flower petal appearance. Yes, but answer is not flower petal appearance. It is cystoid macular edema. And flower petal, because of outer plexiform layer, it goes radially. Mostly edema exudates come due to inner barrier break of the retina in outer plexiform layer, which is a radial configuration like Henle's layer. But I've asked optical coherence tomography. Many people must have answered this flower petal appearance thinking very easy question. That is how you make mistake in the exam. How you make mistake? You saw this and it's flower petal. No, I've asked OCT of this will show increased thickness of the retina. That is the answer of this question. Many people think this very easy question, flower petal appearance, we got 4 marks. No, you got minus marks because you didn't read the question well. You didn't apply that OCT question was asked. I know many people have done this wrong as well. And this is an easy question. I told you 20 above can be scored if you have just seen PYQs and the previous quizzes. So treatment I have told you, CME depends on the cause. Okay, so that's the 3 questions. Okay, let's resume the 4th question. Okay, another previous question. Elderly patient presented with decreasing far vision but improvement in the near vision. That's why near glasses are not required. This is second sight phenomenon. He is getting a second sight due to nuclear sclerosis. That is index myopia. The refractive index of the central lens is increasing, not the eyeball size is increasing. It's not axial myopia. Answer is index myopia. It is due to nuclear sclerosis and far vision is reducing because of myopia. Near vision is improving because in myopia the far point is close to the eye. That's why far vision is improved by concave lenses. That is true. A is answer over here because it is true index myopia because the refractive index of the center of the lens is increasing. If it was a nuclear cataract, then far vision, near vision both are reduced. Then there is no second sight phenomena because that is the central media opacity. Nuclear cataract. Yeah, good, Tarush. Now please expect the question of SRK formula on 11th. Why? Because something happened to your dear Bollywood star SRK. I don't have time to tell and I should not tell because something happened. He got some cataract surgery and something mishappened mishappening happened to him on SRK formula only of power calculation. Now this is a minus 2.5 L minus 0.9 K. A is the material constant depending on the material, that is true. 2.5 L is the axial length of eye, true. K is the corneal curvature, true. But it is not best for post-LASIK. For post-LASIK patients, Haig's L formula is required. That's the answer over here. What extra question they can ask you? In post-LASIK patient, Haig's L formula is required, or Barrett's formula also required, but at your level, Haig's L can be the answer. In small eyes, hypermetropic eyes, Hoffer Q formula is required. In long eyes, SRKT or Holiday formula is required. Most common is SRK formula, which they can ask you at your level. SRK formula, what is it? And 1 millimeter of the axial length changes, 2.5 diopters of the eyeball diffractive error changes. 1 diopter corneal curvature changes, 0.9 diopter refractive error changes. 1 millimeter corneal curvature changes, 6 diopter corneal refractive error of the patient changes. Alright, so answer is D. ये SRK जो था, these are 3 different scientists, not the Bollywood scientists. Something happened to your Bollywood scientist, वो अलग बात है, ठीक है? Incidentally, coincidentally, SRK formula में problem हुआ उसको, या whatever formula was used. He underwent presbyopic LASIK, and then he wanted to undergo cataract, and some multifocal IOL was placed. So you should know about multifocal IOL. So multifocal means which works on far and as well as near. There are rings in the center, as you have learned from the class, that can work for far as well as near, because after cataract surgery, near vision is lost. So because accommodation is lost, so near glasses are given. Multifocal IOL, if you put far and near, it can work for both. But if you have undergone LASIK, multifocal has some problems. That's what happened to your dear SRK of Bollywood, and he went to some other country to get the exchange of intraocular lens. So what are the 2 indications of refractive of intraocular lens exchange? 1, if the IOL is dislocated, subluxated, the natural position is posterior chamber of the eye. If it is dislocated from its position, then you have to take out and put a fresh one. Or the second which happened is refractive surprise, means the power which you have put is not of the correct power, then that is known as a refractive surprise. So 2 indications of exchange of IOL or removal of IOL is this. 1, refractive surprise. 2, IOL dislocation. Otherwise, when you put IOL, it's for lifelong. Okay. Now this question, again a repeat question, retina detachment question, but the answer is not retina detachment. If you have answered, because you have not read the whole properly. Patient with thick glasses since childhood present with certain decrease in visual acuity. In examination, anterior segment is visible. No glow on distant direct ophthalmoscopy means there is no glow coming from the retina. If there is no glow coming from the retina, means something, there is a media. Media is hazy, that's why retina cannot be seen. If retina cannot be seen, you cannot answer retina detachment. This is vitreous hemorrhage. Now some people say the same can happen in retina detachment. Yes, but in that retina will be seen. In rheumatogenic retina detachment, because of high myopia, there can be tears. The fluid can come and separate the 9 layers from behind. That is causing convex retina detachment, which can be seen on fundoscopy. But there is no glow means the answer is vitreous hemorrhage. And what are the classical features of rheumatogenic retinal detachment? Floaters, flashes, field effect followed by sudden painless loss of vision. Okay, so this is a radiology question. There is a bamboo spine appearance that is seen in ankylosing spondylitis, but can be seen in males as well as females. A 22-year-old female complaining with morning stiffness, all are expected. Expectation is anterior non-granulomatous uveitis. All can be seen in uveitis, but mutton fat KPs are seen in granulomatous uveitis. That's why this is the answer over here. Of course, cells, flare, hypopyon are seen in anterior uveitis, but mutton fat KP is seen in granulomatous. Ankylosing spondylitis is HLA-B27 causing non-granulomatous anterior uveitis. Acha, if I ask a question, a person with HLA-B27 having a urinary tract infection comes with arthritis, urinary tract infection and anterior non-granulomatous uveitis, then the answer is, anyone? HLA-B27. Then answer is Reiter syndrome, uveitis, urethritis, conjunctivitis, arthritis. Can be causing most common eye feature is conjunctivitis, but there can be non-conjunctivitis and uveitis as well. Now this is something put inside the cornea of a patient, a repeat PYQ image. It is intracorneal ring segments, also known as ICRS or intacs, intracorneal segments. Now it is done for keratoconus patient, that was asked in the previous question, so A option should have been correct. Now it is not present, it is not in the endothelium. If you know the anatomy of the cornea, endothelium is a single layer. How can you put this in an endothelium? Even you could have answered this question logically. If you know endothelium is a single layer, it is put in the most thickest layer of the cornea, that is stroma. It is made up of PMMA, hard material, and yes, it is reversible. Even if you don't know it's reversible or made up of PMMA, you should know it's done for keratoconus because it was a PYQ, and you should know endothelium is a single layer of the cornea. You cannot place in a single layer of the cornea, you have to place in stroma. That is ICRS for non-progressive keratoconus. Alright, this is the INI CT PYQ. Good answers. Rish, very good. Now, patient of cardiac arrhythmias. In the PYQ, INI CT was a rheumatic heart disease with inferior visual field defect only. Now, if there is an inferior visual field defect, means superior part of the retina might be involved. Means it cannot be central retina artery or vein occlusion. In central retinal artery occlusion, the entire retina is involved. Ganglionic layer edema, maximum in the macula, sparing the fovea. That's why cherry red spot. In central retinal vein occlusion, all the retina has hemorrhages, exudates, and tortuous dilated vein. 1:3, 1:4 ratio of the arteriovenous. Splash tomato, blood thunder appearance in all the retina. That's why B cannot be the answer. Answer can be C and D, yes. But cardiac arrhythmias goes in favor of emboli, and emboli can block the artery. So C is the most probable answer of this question. Branch retinal artery occlusion. What do you do for central retinal vein occlusion treatment? Quickly. Primary is same as proliferative stage of diabetic retinopathy, that is pan-retinal photocoagulation. Secondary is anti-VEGF injections. This question. What is the treatment of CRAO? First is ocular digital massage. Press kar do eyeball ko so that embolus can dislodge. Same as for branch retinal artery occlusion. Second step, you inhale the carbogen. Exhale, inhale 5% CO2, 95% oxygen. And if that doesn't work, decrease the intraocular pressure. That will intraocular pressure decrease can dilate the vessel and embolus can dislodge. Why CO2? CO2 is a vasodilator. 5% क्यों ज़्यादा क्यों नहीं? Patient को मारना नहीं है आपको. 5% enough है to dilate the vessel. But the first thing is very important: ocular distal massage. Branch retinal vein occlusion also answer is you do scatter laser photocoagulation. Only one quadrant laser is done. Secondary is anti-VEGF injection. In central retinal vein occlusion and proliferative stage of diabetic retinopathy, the entire retina is hypoxic. That's why pan-retinal photocoagulation. Okay. In branch retinal vein occlusion, only one segment is hypoxic. So scatter laser photocoagulation is done. Now this is a very important device. I expect a question on this. This is a Goldman applanation tonometer for intraocular pressure measurement. It is used along with slit lamp. Yes, it is not a portable device, and it is used with fluorescent dye. Cobalt blue light is used. I hope you know. You expect a question from fluorescent dye. Orange color dye, blue light comes inside, green goes outside. And you see two prisms or two semicircles in the cornea, and the inner edge of two semicircle meet. That is the correct pressures. So it is avoided in corneal infections. Yes, true, because it is a contact procedure. And it is not based on indentation, it is based on applanation principle. Which law? Which law? Imbert-Fick law. It is a contact procedure. Almost all the tonometers at your level are contact procedure except non-contact tonometer, that is pulsar, and one more that is non-contact but not of your level. I don't know. I don't think so. That will be asked. Ocular response analyzer based on corneal hysteresis. But pulsar or non-contact tonometer you can remember as preferred in corneal infections. Which is preferred in corneal opacities? Tonopen. Expect a question on investigations of glaucoma. Very important. Gonioscopy, tonometry, visual field is always important. Optic test evaluation, the best is slit lamp plus lenses. Now, I hope you have solved the INSET question of previous May, because that is also very important. The 3 questions I've given from there only, but with a slight twist. Let us see if you can answer this question. 80-year-old male patient with diminution of vision since 2 years. 80-year-old. Left eye was red and painful. IOP was 50, and there was deep antechamber. Now, only from deep antechamber we can rule out malignant glaucoma and phacomorphic glaucoma. Phacomorphic glaucoma, the lens is swollen, is pushing the iris forward, and iris is blocking the angle, means it is a secondary closed angle. Antechamber is shallow. IOP is very high. Malignant glaucoma is inverse glaucoma or aqueous misdirection glaucoma. The aqueous goes into the vitreous. Vitreous is like a jelly. Vitreous pressure increases and pushes the iris forward. Again, shallow antechamber and high IOP. So, malignant and phacomorphic cannot be the answer of this question. An acute angle closure has, of course, pupil block glaucoma. The aqueous is formed and it is not able to come to the antechamber because of pupil block. Again, this is shallow antechamber and shallow antechamber and high IOP. So, only if you know which are the causes of shallow antechamber and high IOP, malignant, phacomorphic and acute angle closure are shallow antechamber with high IOP. Answer is phacolytic glaucoma. Now, phacolytic glaucoma is seen in old age, yes, because of hypermature Morgagnonian cataract. In hypermature cataract, the lens size is already small, so antechamber is already deep, and lens proteins can come out and block the trabecular meshwork, causing secondary open angle glaucoma, deep AC. And some cells and flares. Some students have asked me, sir, cells and flare are seen in uveitis? Cells and flare can be seen in any inflammatory condition. This is secondary high IOP, which has some inflammatory condition. Even acute angle closure has some cells. Sometimes they write this only to confuse, but there was no option of uveitis. Okay, so that's why answer is phacolytic glaucoma, also known as lens protein glaucoma. That's why the B answer is there. Good, Trish. Okay, let's resume the quiz. Now, this device again is a previous year question, is a Hertel's exophthalmometer. The usefulness is mostly in proptosis, ptosis and myasthenia. Congenital ptosis and myasthenia gravis both have ptosis. Myasthenia gravis, the most important eye feature is ptosis. Ptosis is drooping of the upper eyelid. Lacrimal gland tumor is the answer because that is causing non-axial proptosis. This can be used for axial, non-axial, yes. Who said it is only for axial? It can be for non-axial as well. Preseptal cellulitis don't have proptosis. That is the differentiation of preseptal from orbital. मैं थक गया हूँ बोलते. 3 features goes in favor of orbital: proptosis, vision decrease and ophthalmoplegia. If these 3 are present, it cannot be preseptal cellulitis. So answer is not preseptal. Answer is lacrimal gland tumor. It is causing non-axial. I hope you know non-axial means it is not coming into the center. Give me some example of axial proptosis. Optic nerve tumors like glioma, meningioma, and thyroid eye disease, most common cause of unilateral bilateral proptosis. Who can answer me this question? A 6-year-old girl comes to you with mild proptosis and Marcus gun pupil. On swinging flashlight, there was a Marcus gun pupil, mild proptosis, capsuloid spots all over the body, axillary fleckling, some optic nerve tumor. What is the answer? Enrich syndrome. Fusiform appearance of the optic nerve. Answer is optic nerve glioma. Least nodules can be seen on iris. Neurofibromatosis 1 and 2. More in 1. Now straight away question. Glycosaminoglycan absorb water. That's why, and they are in the stroma. That's why stroma is the thickest layer of the cornea. Keratin sulfate can be present. Heparin sulfate can be present. Most common is keratin sulfate, which maintains the corneal transparency as well, because it will not allow the aqueous pressure, the aqueous to come imbibe into the cornea. And that is why in acute intraocular pressure, like in acute angle closure, the aqueous can imbibe into the cornea, leading to corneal edema. So answer is keratin sulfate is the most common glycosaminoglycan, which is maintaining the transparency of all the glycosaminoglycans in the stroma. No, Yash, answer is NF. Now one squint question, the extraocular muscle, which is the adductor of the eye. Theoretical adductor, let us rule out. Obliques are abductors, so A and C are ruled out. Superior rectus, inferior rectus might be the answer. But it has a maximum elevation in abducted position. Even if you don't know this, elevation is by superior rectus. So answer is SR. But it is why in abducted? Because the eyeball with SR is inserted 23 degrees to the eyeball. So if you want to align the eyeball to the SR, you have to abduct to 23 degrees. In that, it is a pure elevator. So it is a maximum elevator in abducted position of the eye, and theoretically it is an adductor as well. That is IR. That is superior rectus. Okay. Now this is the retina, left retina of the patient. This is the optic disc. These are the vessels, central vessels, which you can see. Now you can see some pigments in the peripheral retina. Now this is the most important or most common corneal dystrophy, that is retinitis pigmentosa. It's an inherited disorder. It's a dystrophy of photoreceptors, means rods and cones. Rods more than cones. That's why the early feature is night blindness, not the late feature. This was also the INSET question. And both A and B ERG can be reduced. First A and then B, because A is because of rods and cones, B because of bipolar and Muller. So A is first reduced and later B, because later on all the layers can be involved in retinitis pigmentosa, but night blindness is an early feature. 2 vitamins are decreased in pigmentosa, one vitamin A and docoxahexaquinoic acid. Delayed dark adaptation also is a feature. Photostress test is increased in retinitis pigmentosa. Okay. Now the abnormality is this white dandruff-like material on the lens. Again a previous year question actually. If you are getting this wrong, previous year questions, that is not correct. पाप है previous year question को गलत करना. This is pseudo exfoliation glaucoma, most common secondary glaucoma. Who can tell me, seen in old age, young age? Seen in old age. And dandruff material can be placed anywhere in the eye. Here it is above the lens, can be at the pupil, can be at the trabecular meshwork, causing secondary open angle glaucoma. Later on it can pull the iris upwards, so later on can be closed angle glaucoma. It is the most common secondary glaucoma, pseudo exfoliation. Osseous ring is the pigments of iris on the lens, so brown pigments will be there. And new vessel glaucoma, if they want to ask, they will show you new vessels on the iris. Pigmentary glaucoma picture usually they won't ask, but pigmentary glaucoma, very important question. Secondary glaucoma is also very important. I gave in the predictors. A young male particularly coming with high pressures after exercise, that is pigmentary glaucoma, because of a reverse configuration of iris. That's why it is known as reverse glaucoma. Iris can rub onto the zonules. Iris pigments are dispersed all over the eye, causing secondary open angle glaucoma. Loosening of the iris pigment, so iris trans illumination defects, and Krukenberg spindles are pigments on the posterior surface of the cornea, that is endothelium of the cornea. That is pigmentary glaucoma. Now, inability of the eye in closing in the primary gaze is known as not lid-lag sign. Lid-lag sign, as the name suggests, eyeball goes down, eyelid is lagging in down gaze. Lid-lag sign is positive in congenital simple ptosis and thyroid eye disease. Proptosis is protrusion of the eyeball. This is inability of the closes, lag of thalamus. Ptosis is drooping of the upper eyelid in primary gaze. So this is lag of thalamus due to which nerve palsy? 7th nerve palsy, mostly because 7th nerve supplies orbicularis. Orbicularis oculi present in both upper and lower eyelid. It closes the eye. So in Bell's palsy, lag of thalamus can be seen, leading to exposure of the cornea, exposure keratitis, also known as neuroparalytic keratitis. Treatment is patch the eye, or what is the closure of the upper and the lower eyelid, known as tarsorrhaphy. But which is the phenomena in which when you close the eye, eyeball goes up and out? Bell's phenomena due to 3rd and 7th nerve. If the Bell's phenomena is good and the patient gets Bell's palsy, the chances of exposure of cornea are more or less? Please type and tell. Less. Because in Bell's palsy, if the Bell's phenomena is good, when you close eyes, eyeball will go up and out, 3rd and 7th nerve involved, so corneal exposure chances will be less. For the prescription of glasses, expect one question because this was recently asked. The patient was having only +2 diopter cylinder, means astigmatism is there, that's why cylinder is put. Now student will ask, sir, where is spherical? Nahi hai spherical, 0 मान लो. If plus 2 diopter spherical has 90 degree means vertical axis, it works in horizontal axis. I hope you know this. Cylinders always work at 90 degree to where it is kept. So vertical is 0 and horizontal is plus 2. 0 means the rays in vertical axis are focused on the retina. Plus 2 means the rays are focused behind the retina. Means simple hypermetropic astigmatism is there. And the more in front axis is more steeper axis. The cornea curvature of that axis is more. So vertical axis is more steeper because that is more in front. So that is known as with the rule astigmatism. So this is simple hypermetropic astigmatism with the rule, not against the rule. That is the answer of C is the answer. Vertical axis 0, horizontal plus 2, and corneal curvature of the steeper axis is more. Steeper is vertical axis. That is why known as with the rule astigmatism, not against the rule astigmatism. Please expect a question on optics. Very, 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 very important. On this prescription of glasses or the retinoscopy values as well. Good. Alright. Now this is the upper palpebral conjunctiva. This is papilla. Papilla can be seen in allergic conjunctivitis. Allergic conjunctivitis can be vernal keratoconjunctivitis, giant papillary conjunctivitis, fleck-tunnel conjunctivitis. Then fleck-tunnel, there is a flecked nodule at the limbus. Here it is papilla, can be seen in vernal kerato, a young boy coming with itching, ropey discharge, mostly in summers. That is vernal keratoconjunctivitis with Horner-Tranta dots, shield ulcer in the cornea. IgE mediated, type 1 plus 4 hypersensitivity, but type 1 is more. So IgE mediated, that's why there are mast cells, eosinophils. But it is also known as spring catarrh, but that's a misnomer. वो स्प्रिंग में क्यों होता है मुझे आज तक नहीं पता. इतने साल जैसे मैं क्लास में बताता हूँ 100 years I've been teaching ophthalmology, आज तक मुझे नहीं पता इसको स्प्रिंग कटार क्यों कहते हैं. आपको पता लगे तो मुझे मत बताना, मुझे कोई शौक नहीं है जानने का. बट ये मिसनोमर है. इट्स सीन इन समर्स नॉट स्प्रिंग्स. बट इफ देयर इज अ foreign body reaction to sutures or contact lens, then it's a giant papillary conjunctivitis. Now सिर्फ picture देखे you cannot tell it's a vernal kerato or giant papillary. History has to be there. So history is given of a boy with itching, khujli aa raha hai, foreign body sensation, can be a ropey thick ropey discharge like a Maxwell-Loin sign. The following sign papilla is seen, that is a not giant papillary, that is a vernal keratoconjunctivitis, not seen in spring. It is Ig mediated. That is the answer. And topical antibiotic has no role. It is an anti-inflammatory. Olopatadine, mild steroids are given, or sodium chromoglycate can be given. Ig mediated is the answer of this question. Now many people have got this question wrong as well. It is a diffuse picture of the lens. Anything white in the lens is cataract. That's why it is known as safed motia. Kala motia is glaucoma because optic nerve damage, irreversible damage. This is A is the lens, B is also the lens. A is periphery, B is the nucleus which has gone down. Lens has not gone down. It is not subluxation. It is a hypermature Morgagnian cataract which can lead to Phacolytic glaucoma, which I explained. Lens protein glaucoma. So answer is not lens subluxation. It is hypermature Morgagnian cataract leading to secondary open angle glaucoma. A is the cortex. B is not lens subluxation. B is a nucleus which has gone down. And yes, it is seen in usually elderly, like a question I gave you 80-year-old. What is the treatment of Phacolytic? Cataract surgery under IOP control. If you don't control the IOP, who can tell me what complication can occur? If the pressure is very high and you do cataract surgery in very high pressures, which is the most dangerous complication of cataract surgery, in which the patient intraoperatively everything comes out of the incision, some bleeding between the choroid and sclera, posterior ciliary vessels bleed, everything comes out. What is that? जिसमें आपको प्रे करना पड़ता है, क्लास में बताता हूँ. एक्सपल्सिव सुपरकोराइड हेमरेज. Now cricket ball injury means there is a blunt trauma. In blunt trauma, even ruptured globe can be there. If there is so much trauma because of high pressure, globe can rupture. Rosette cataract, yes, it is a traumatic cataract. Washer's ring is seen in blunt trauma. Chalcosis is seen in penetrating trauma, that is copper going inside the eye. That is the answer over here. What are the features in blunt trauma? Periorbital hematoma known as ecchymosis. Okay, quickly if I just revise with you. Blunt trauma features. Ocular injury is very expected, like a chemical injury. What is the first thing which happen in chemical injury? First thing you do is wash the eye. But yesterday I gave a question on corneal abrasion. Is this abrasion by oh ये देखो ये क्या हो रहा है, कौन सा इंजरी है? ये भी blunt trauma है ना? Ecchymosis. Please tell me what is the sign. Actually, yesterday I gave a finger nail injury. Corneal abrasion is there. then you stain to see the epithelium defect with fluorescent dye, cobalt blue filter, and then patch the eye. You don't do copious irrigation unless and until there is a chemical injury. So this is ecchymosis, that is periorbital hematoma, subconjunctival hemorrhage. Nothing to be done for subconjunctival hemorrhage. It cannot be blanched by phenylephrine also. What is this? Floor fracture, maxillary bone fracture, blowout fracture, teardrop sign. This is hyphema. All these are seen in blunt trauma. This is the Vossius ring, iris pigments on the antral lens capsule. This is D-shaped pupil, that is iridodialysis. This is the one I gave you, rosette cataract. And this is the one, Berlin's edema, cherry red spot, maximum edema in the ganglion, sparing the fovea. Which condition has fovea involvement only? Only fovea involvement, like a bullseye. That is bullseye maculopathy. That is due to chloroquine, high toxic chloroquine. Alright, so that is a quick revision of the blunt trauma features in the eye. True for levator palpebrae muscle. Okay, levator palpebrae is present only in the upper eyelid. That's why the name is superioris. Levator palpebrae superioris elevates the eyelid more than 15 millimeters. Origin from the apex of the orbit, from the lesser wing of sphenoid, roof of the orbit, and maximum insertion in the anterior tarsus. Can insert into skin of the eyelid, forming eyelid crease, horizontal line. देखा आपने आपको शीशे में कभी ऐसी horizontal lines होती हैं, upper में होती हैं, lower में नहीं होती, because there are eyelid crease formed by eyelid insertion into the skin. Some can go into lateral medial canthal tendon, but maximum in the anterior tarsus. There is a single nucleus in midbrain supplying both muscles. That is a true statement. Even if you don't know, you should know it is not present in lower eyelid. You should know it is supplied by third nerve. You should know it is originating from apex, not the base. Even if you don't know A, you can answer. MCQ is a game of 3. You should know correctly the three options, other three options, whether true or false. Fourth automatically becoming the answer. So LPS has a single nucleus. That's why in nuclear third nerve palsy, bilateral ptosis is there. Now please expect a question on visual field defect as well in on 11th August. Visual field defect, quickly if I just revise from anterior to posterior. Quickly if I just go, when there is a, always when the visual field is given to you, it is taken as a patient's view. So for example, I'll just quickly revise the visual field for you. Visual field defects only, of course. When there is a problem in the visual pathway, it comes in neurophthal. Okay. So when there is a right optic nerve lesion, only right side visual field defect, right anopia is the answer. When optic chiasma lesion, right or left? Optic chiasma एक ही होता है. Optic chiasma lesion, bitemporal hemianopia. Right optic tract lesion. Whenever the lesion is behind the chiasma on the right side, it is always contralateral homonymous. So right optic tract, right temporal fibers are not working, so right nasal defect. Left nasal fibers are not working, so left temporal defect. So left homonymous heminopia is the answer. In LGB, there is a contralateral keyhole visual field defect. Picture won't be asked, question won't be asked. Keyhole vision is seen in occipital lobe lesion. Keyhole defects are seen in LGB. And optic radiation passing through temporal lobe only involves the inferior radiation fibers. So contralateral homonymous superior quadrant anopia, that is pie in the sky. Parietal lobe is the question. Contralateral homonymous inferior quadrant anopia, because superior radiation fibers are involved. And in occipital lobe lesion, there is a contralateral homonymous heminopia with macula sparing, because mostly they ask PC occlusion, even if they don't mention, because the tip of the lobe has additional supply from MCA, which represents the macula of the retina. So macula sparing gives a keyhole vision, not a keyhole defects. So here in the question was parietal lobe will have contralateral homonymous inferior quadrant anopia. Now what is the first defect of pituitary tumor? The tumor is coming from below. So bilateral supratemporal quadrant anopia, but that is heteronymous and that will progress to bitemporal. That's why that is not known as pie in the sky. While craniopharyngioma, the tumor is coming from above in Rodke's pouch. So it will be heteronymous, bilateral, inferotemporal, heteronymous quadrant anopia, not pie in the floor, because that will also progress to bitemporal heminopia, because that is a heteronymous defect and that will progress That's why pie in the sky is reserved for temporal lobe, pie on the floor reserved for parietal lobe. So that's the 23rd question. 24th question, if someone has answered sympathetic ophthalmia, please don't attend the quiz after this. 100 times I've told you, sympathetic ophthalmia due to penetrating trauma in one eye, yes. But sympathetic ophthalmia means the other eye, fellow eye has type or hypersensory reaction due to trauma in this eye. Here only penetrating injury, vegetable matter, restricted eye movements, vision loss, no light perception, corneal infiltrates, eyeball restriction means sclera is involved because muscles are attached to the sclera. Only one eye problem is given. And cornea sclera is involved means there is all the layers of the eyeball is involved, that is panophthalmitis. Endophthalmitis means the cornea sclera are spared, that is infection inflammation of the inner layers of the eyeball, sparing the outer fibers, that is cornea sclera. Cornea sclera is involved, written clearly, corneal infiltrates, restricted eye movements. Even if you don't know restricted eye movements, corneal was given, corneal infiltrates with pus is there. Now some people ask, what is the difference between end-of, pan-off and pan-uveitis? They are pan-uveitis, they are purulent pan-uveitis. Because pus is there, infection is there. Which is the most common infection after post-cataract surgery endophthalmitis? Staph epidermitis. Presents after 2 to 3 days, 2 to 5 days of cataract surgery. But most common after glaucoma surgery organism is Streptococcus. Treatment is intravitreal antibiotics. If that is not able to solve, vitrectomy is done. But first intravitreal. But when there is a very poor prognosis, like vision is less than hand movements, then vitrectomy can be done. Or when medical management fail, then vitrectomy is done. Treatment of panophthalmitis, if I have the treatment here, you have to save the eye. So systemic antibiotic. Please remember, systemic antibiotic have no role in endophthalmitis. Systemic antibiotic is the treatment of choice for panophthalmitis, but here there is no light perception. So here if I give the question, systemic antibiotic and second is evisceration or third is enucleation, then answer is evisceration. Painful blind eye in panophthalmitis, evisceration is done. You take out everything from the eyeball, leaving behind the sclera, so that you can put a spherical implant. Why you are leaving sclera? Because why don't you do enucleation? If you touch the sclera, infection can spread to the orbit. Orbital cellulitis can occur. That's why enucleation is contraindicated in panophthalmitis. Like evisceration, if you scrape intraocular tumors and take out. So evisceration is contraindicated in intraocular tumors like retinoblastoma, melanoma, choroidal melanoma. Retinoblastoma is the most common intraocular tumor in child. Choroidal melanoma is the most common intraocular tumor in adults. So evisceration is contraindicated in intraocular tumors and enucleation is contraindicated in panophthalmitis. I am Shobhan, I didn't understand your question. I am why not ipsilateral? I don't understand. Okay, so that was your 20. Which question? Let's resume and then we'll see. Okay, 25th, last. Uncomplicated cataract surgery. Patient was called next day. Following findings: visual acuity slightly less, mild corneal haze, anterior chamber shallow, 8 mm. So this is anterior chamber shallow and low IOP. What are the three differentials of anterior chamber shallow and high IOP? All the three I mentioned today only. It can be suprachoroidal hemorrhage, it can be post-op as well. Second, pupil block mechanism. Third, malignant glaucoma, that is aqueous misdirection glaucoma. This is shallow AC means something is coming out. What something? The fluid, the aqueous is coming out, the wound is leaking. And serial test positive means the wound is leaking. So this is answer is incision, leak, wound leak. Serial test means you put a dye over eye. Dye dalo aankh mein, dye over eye. Which dye? The same orange color dye, fluorescein. See under slit lamp, under cobalt blue light, if the dye is coming out, if the aqueous is coming out, the dye will become diluted. That is known as serial test positive. So who can answer this question? If in entire ophthalmology, if you see serial test positive, what is the next step to be done? Next step to be done is resuturing in operation theatre. OPD mein mat karna baith ke. So wound leak is the answer over here. Which is the most common complication of cataract surgery? D option, PCO. In that, laser capsulotomy is done by NDAC, photodisruptive laser 1064. Here answer is wound leak. So that is 25 questions. Now if you, of course in Telegram quiz you have to answer, but if you see such question in the exam, Durov-Pavel syndrome, who is he? He is your friend, maybe my friend, because we use his product daily. Why I gave this, you see this is, oh देखो नंगा पुंगा बैठा, he is Telegram owner, he was. So my thing, why I gave this Pavel Durov syndrome or any XYZ syndrome, if you see, which you have not heard or hearing for the first time, क्या करोगे ऐसे एग्जाम में? ऐसे क्वेश्चन आएंगे, जरूर आएंगे. ऑन 11th August there will be 10 questions minimal like this which you have not heard or hearing for the first time. उनको छोड़ देना, you will leave it, because ऐसा कोई syndrome आपके लिए exist, ये होता ही नहीं है कोई syndrome. There is no syndrome like this. And you will find many questions in the exam, at least 10 questions जिसमें कोई सुध बुध नहीं है, आपको पता ही नहीं होगा ये हो क्या रहा है. आप उसको एग्जाम में टच नहीं करेंगे. You will leave that question in the exam, because if you attempt, 90% chances you will get it wrong. Of course you can play with your a question that maybe it is correct by fluke. Only 10% chance it will be correct by fluke. So please leave such questions. Okay, now if in other questions which you have seen, if you are able to rule out two options, absolutely completely you are able to rule out two options, please definitely attempt that question. If you have ruled out one option only, then there is a risk 50-50%. Then that's your choice. But if you see such questions like this Pavlov, please, there is no syndrome like this. Please don't ask me, sir, iska answer kya hai? Nota hai, none of the above. Hai hi nahi, there is no syndrome like this. So that is your 25 questions, 20 plus, 20 or 20 plus should be the good score in this. Even if you're not good, don't get disheartened. You attended this, maybe you will get similar some insight. Maybe some questions are asked on 11, maybe which just if you want to quickly see the quizzes again, that will be, I think, more than sufficient. Sometimes that can click in the exam. So don't get disheartened if you're getting less than 20. Why I'm telling more than 20? Because that is a boost. If you're 20 and plus, you will be a little confident. But don't be underconfident if you're not getting 20. Doesn't matter. 15 to 90 means you're making some mistakes. So don't worry about that. Try and learn where have you made the mistake, and don't make the mistake. All these quizzes are there so that you don't make mistake in the real exam on 11th. Okay, that is from all my side, and best wishes to everyone. My one recommendation, don't read after 8 o'clock at night. Even if you have a morning shift or evening shift, just after 8 o'clock close everything. That is my advice. It's your choice to take whatever time, but after 8 o'clock just relax. Your mind will be there. You can just see here and there, you can see your wrong copy, you can see something, but just don't pile up at the end. Just relax, because when you relax, at least 10 questions are correct in your main exam if you're relaxed, and those 10 questions can be wrong also if you're not relaxed. Okay, so best wishes from my side. I hope you see on the other end, and do well on the 11th August. Thank you very much.